We are live now.
So very good afternoon, doctors.
Sir?
So I think doctors left, so I think.
Okay. So ma'am has joined. You can continue.
Ma'am, shall we start, ma'am?
Yeah.
Yeah, ma'am, we are starting session.
Okay.
So very good evening, doctors. I'm Dr. Stalin on behalf of Shield Healthcare, welcoming you all for the today's webinar. The topic for today's webinar is menopause management. I welcome all the participants and I request them to post their queries, if any, in the chat box so that we can have a short Q&A session at the end of this presentation. Now it's time to introduce our invited speaker for the day, Dr. Madhavi Latha, ma'am. Madam has done her MBBS, DGO and MRCOG from RMC Rangaraya Medical College, and Madam is also a gold medalist from the same college. Madam has various experience as consultant in Prashant Hospital, Chennai and Apollo Hospital, Chennai. And currently, Madam is consultant at Kalyani Hospital, Payakarao, Pet. So with this short introduction, I welcome you, ma'am. I'm handing the session to you for your presentation, ma'am. Welcome.
Thank you. Thank you, Dr. Stalin. Good afternoon, everyone. Thank you, Sheel, for giving me this opportunity. And my topic for today is menopause and its management. To start with, menopause is the name derived from the Latin word meno means monthly and the pause is to stop. So that is how the word menopause is discovered. And here, according to the World Health Organization, natural menopause is defined as a permanent cessation of menses. It's only confirmed after 12 consecutive months of amenorrhea. We call it as menopause. And in general, the menopause occurs between 45 and 55 years of age. But in India, the range of mean age at menopause reported in different studies appear to be between 41.9 to 49.42. This is quite low on the lower side when compared to the remaining people in other countries. So it's quite emerging as a newer problem in our country right now. So next slide, please. So we can see this slide, which is this is the study which was done by National Family Health Survey, and here they considered they've taken into consideration age groups between 30 to 49 years, and here what we can see is in this age group we have seen that 19.3% around the age of 40 to 43 years have reached menopause. So when they're considering this survey, they're doing this survey, they were taken into consideration only the last menstrual period. And In India, usually when there are 6 months of amenorrhea, they're usually considered as amenorrheic and menopausal age, and they've taken into consideration various other factors. And they have noted that the age group in which the reaching the menopause is quite lower in our Indian population. So why is this happening? So when they've taken into all the consideration of various factors here in India, why the menopause is at a lower age when compared to the other people in other countries, they have taken into consideration like low socioeconomic status, the nutritional status of the people, and also and the lower educational rates when compared to other countries in our country. They're all contributing to this earlier menopause because of higher education and high socioeconomic status. Other people are taking better health choices when compared to people in India. And so this is a new emerging problem in India, which is really neglected because in our population, what we consider is we take into consideration all the menstrual problems. We give a lot of importance to them. We give a lot of importance to the other problems in pregnancy. But comparatively, we don't have much focus on the menopausal symptoms, or we don't even focus what's happening and we don't educate also. So women actually spend more than half of their life, or at least half of their life in menopause. So a lot of importance and education has to be given regarding the menopause and its management because this is creating new problems. So the morbidity is increasing in menopause. So we have to consider that. And so it is an important topic like menopause and its management. Next slide, please. So here, when we look at all these studies, the menopausal age, and also you can see notice that the premature menopause also like premature ovarian failure rates also are increasing in people in India. And when we consider, and in this study itself, when the National Family Health Survey was done, considering various states, we can see that Andhra Pradesh is having the highest rate of premature menopause, as well as the menopausal age, the lower age is having, Andhra Pradesh is having the highest rate. Next comes Karnataka and next comes Bihar. Whereas the rate is lesser in Kerala. So maybe the nutritional status and the education status is also varying in various different states, but this is under study. So we have to see what is actually contributing to this earlier menopause in people in Andhra Pradesh compared to Kerala also. So that is also the study is going on now. So the proportion and absolute number of Indian women at the age 45 years and above is likely to increase substantially. This is what I'm speaking. In the next few decades, even this age is group is going to come down in the next future. So we have to focus on this. And as the postmenopausal years are associated with health risks, as well as there is a fertility challenges also because the fertility issues also have to be taken care when they're having menopause or reaching the menopause at an earlier age group, we have to even consider the fertility aspects of these people as well. So apart from that, as the postmenopausal years are associated with other risks like hypertension, heart disease, and osteoporosis and decline in the overall quality of life, like short-term consequences and long-term consequences we have. So they have presenting profound future challenges in the menopausal age group. That is what we have to deal with. Next slide. So menopause, each person have individual, like they have the quality of symptoms or what the amount of symptoms they're having may vary from person to person because each woman have the different symptoms and different onset and different what we say different amount of symptoms that are presenting with. So each woman has to be individualized treatment must be given to each woman. And we have to distinguish between a symptomatic and asymptomatic woman because in some women they may not have any symptoms, but still they are at risk of cardiovascular diseases at a later age and osteoporosis also. So we have to consider the patient and aging and also the background factors and what actually they require. If in case there are premature ovarian failure who's looking for fertility, so the treatment may be different when compared to people who are having a background risk of cardiovascular defects and also different from vasomotor symptoms. So every person must be having their own individualized treatment and approach must be like pertaining to each patient. That's what we have to consider when treating these patients with menopause. Next slide, please. So what are the symptoms of menopause? There may be varied symptoms of menopause. There is which we call a symptom complex. We can divide them into short-term consequences and long-term consequences. The short-term consequences which we usually face across is here vasomotor symptoms, somatic symptoms, and genitourinary syndrome of menopause and neuropsychiatric symptoms. These are the short-term consequences. And also the bleeding problems. These are all short-term consequences of menopause. Whereas long-term consequences, we can consider them as like cardiovascular risk factors, osteoporosis, and cognitive decline. These are all the long-term consequences of menopause. So we'll discuss them individually, like each one. First one, next. Next slide, please. So what happens in the bleeding problems? What happens in menopause is there can be varied symptoms. Like actually, they will be presenting with a shortening of cycles that occurs in later reproductive years. And what happens is between the shortening of the cycles and excessive bleeding may be there. So heavy cycles may be there. And then what happens is later the length of the cycles increases and intermenstrual interval may increase, and suddenly they may have cessation of bleeding. So this is what actually happens. But we have to be mindful when we're treating the patients with menopause, because in this, when heavy cycles may be a part of menopause, but sometimes when there is intermenstrual bleeding or excessive bleeding, which is not being regressing with any treatment, we have to consider other factors also, and we have to take into consideration if there is any hyperplasia, and so everything must be ruled out when we are treating with this menopausal age group who are having heavy bleeding. Next slide, please. And what are the vasomotor symptoms? Vasomotor symptoms is the second most common symptoms which actually the people with menopause present. And these are the most bothersome symptoms of menopause and the most common reason why actually people come for treatment. What is happening in vasomotor symptoms is we have hormonal imbalance where the estrogen level comes down when in menopause. So estrogen levels, what happens is they maintain the homeostatic mechanism in the brain is maintained by this estrogen hormone. When there's sudden regression of the estrogen hormone, there is imbalance in the thermoregulation. So that's the reason for this vasomotor symptoms in menopause, associated with a sudden sensation of heat in the face, neck, chest, and persists for several minutes or less. And during a hot flush, what happens is skin temperature rises due to peripheral vasodilatation, particularly in the fingers and toes. Along with peripheral vasodilatation and sweating, heart rate also increases, and the time interval may be different for each person. It may take 30 minutes or longer for the skin temperature to return to baseline. And also, next slide, please. The vasomotor symptoms may start just before the onset of menopause and last for 3 to 4 years after the menopause. So again, here it is individualized approach because each one may present differently. So a key finding was the median duration of hot flushes reported by women to be moderate to severe was 10.2 years. This is the average thing. So it may be presenting either in the perimenopausal age, menopause, or after postmenopause also. So women whose symptoms began around the time of onset of the perimenopausal transition, it was a much higher. The median duration of symptoms was 11.6 years. And what are the somatic symptoms that they will be presenting with? Joint aches and pain are the commonly reported symptoms among women at midlife. And women who are obese or depressed are more likely to experience the joint pains. And peri and postmenopausal women experiencing more joint pain than with the premenopausal women, because the weight also, obesity also will play a role in this, as well as the menopause and aging also can have a role in the somatic symptoms of menopause. Next slide. And the body composition also will be differing in menopause because of this. What happens is typically gain weight during midlife, and it does not appear to be due to menopausal status or stage. But in early postmenopausal years, what happens is they typically gain abdominal fat mass and lose lean mass. So we can see that the shape of appearance also will be different in the menopausal women, because most of the fat will be deposited either in the thighs or in the back or in the abdomen, lower abdomen. So you can notice that change in the menopausal years. The fat distribution will be different when compared to the premenopausal and menopausal women. Next slide. And because of the collagen content also, because of the hormonal imbalance, collagen content also will be decreasing in the body, because of which we can see this wrinkles and fine lines on the skin. And also because of this osteoclastic activity, which is also because of the decrease in estrogen levels, can lead to skin bone problems as well. So because of this decrease in collagen and calcium levels in the bones, we can see the bone and the skin problems also. Along with that, we can see the hirsutism because of this estrogen, peripheral conversion of estrogen to androgens. And genitourinary syndrome of menopause. We generally notice lot of estrogen receptors on the bladder, urethra, pelvic floor, and also in the lower vagina and vulva. When the estrogen levels come down during menopause, which actually happens because of the menopausal age, there can be a lot of adverse effects both the genitals and the urinary system. So recently what they have done is they combined all these symptoms together and they've named it as the genitourinary syndrome of menopause, where we can see a lot of urinary problems as the genital problems. They have sexual problems as well. So what happens because of this genitourinary syndrome of menopause is adversely affects health, sex life, and quality of life of the many menopausal women. And the prevalence of urogenital symptoms in the postmenopausal in the International Menopausal Society study was 15%, and they commonly present as vaginal dryness in 32%, pruritus in 10 to 17%, and dyspareunia and urinary urgency in 10%. What happens in this age group is there is a taboo that they don't express what's happening and they don't come for seeking any treatment. So whenever we see or come across a patient with symptoms of genetic and genitals and urinary system, we can ask them so that they can express themselves and we can educate them that that is a part of menopause and we can treat the symptoms when they come to us. Next slide, please. So what happens of this because of this menopause is there is a vulvovaginal atrophy, and because of this reduced vulval fat and reduced vaginal rugae and blood flow, all these lead to pale appearance of the vagina. And what happens to the pH? pH is usually between 3.5 to 5 to neutral range in the vaginal pH. What happens in menopause because of this decline and this there is a decline in the there is a shift in the vaginal maturation index as well. So the vagina becomes very pale and also it becomes very dry. So we can use actually the vaginal lubricants and vaginal moisturizers can be offered for vaginal dryness and dyspareunia. So what is the most suitable one? Is it a lubricant or a vaginal moisturizer? Lubricant have only short-term relief, whereas vaginal moisturizers, because they stick to this vaginal lining, they are more suitable than vaginal lubricants, and long-term effects will be better with a vaginal moisturizer than compared to a vaginal lubricant. And local estrogen therapy is also first-line management of all these sexual problems like dyspareunia, and also urinary problems also can be sometimes treated with this local estrogen therapy unless until you have any contraindications like any actively estrogen dependent tumors. Apart from this, you can use this local estrogen therapy in all the menopausal cases to treat either the genital problems or the urinary problems, depending on the intensity of problem they have. So what is the sexual problems? Vaginal atrophy with aging may lead to dyspareunia, causing sexual dysfunction, which is corrected by the local estrogen therapy. And there is also hyposexual disorder, like there is a loss of libido in these patients. And women who do not respond with this estrogen therapy, they can be offered testosterone. But this testosterone supplements, which are regularly prescribed to be male or should not be given here. And the other option is tibolone. Tibolone is an steroid which is contains both estrogenic activity, and progesteronogenic activity. So tibolone is also a good option since it contains androgenic activity and can be used to treat libido problems. And other next important symptom which they come across in this menopausal age group is we have a lot of what happens estrogen. What actually it does is it has an effect in the neuronal circuit of the brain. Neuronal circuit, it connects, various connections will be there in the brain because of this estrogen and keeps our brain activated because of this all this neuronal connection when estrogen is in balance. But what happens because of the decline in the levels of the estrogen, the core mental functions like memory, communication, ability to focus and pay attention, reasoning and judging, and visual perception all may come down because of this. And if any impairment of any two functions is suggestive of dementia, and many dementias are progressive. So early identification will be giving them maximum benefit when we treat them, when we identify earlier, and opportunity to plan for future. Next slide. For best preservation of memory and cognition, women should be advised about the importance of good overall health, good cardiac and vascular health, exercise, maintenance of active mind, avoidance of excessive alcohol consumption, and measures to reduce risk of diabetes and hypertension. And at present, the hormone therapy is not indicated for neuroprotection. Next slide. And there is a significant increase in risk of new onset depression in women during the menopausal transition compared with the premenopausal age group. So there was a study which was done which showed that the people in premenopausal and menopausal, the women around this perimenopausal age group are more susceptible for this depression, because maybe because of this, because of the aging factor, they can have some other problems. Apart from that, because of this estrogen levels decline, what happens is they have an effect on the serotonin receptors and noradrenergic receptors in the brain. And all these circuits are not well balanced because of the estrogen levels. They are particularly higher in this hypothalamus and the amygdala and hippocampus. So when there is a lack of all these hormones because of this estrogen decline, there is lack of all these hormones, and people are more susceptible for this cognitive changes as well as in the depression also. So when we have the studies looking at all the perimenopausal age group, comparatively the depression or new onset of depression is much more higher in this perimenopausal age group. So, and definitive role of the hormonal therapy for treating cognitive symptoms is also lacking. So it's not there for the dementia and not there for the cognitive changes also. Hormone therapy is not recommended nowadays. Next slide, please. And sleep disturbances are also higher in this menopausal age group. The sleep disturbances, sometimes what is it, they have because of this excess, maybe because of the general aging process, like the nocturnal urination, one thing, and chronic pain or depression, and because of the stress and negative mood and ovarian hormone changes, and also because of this hot flushes, they may be experiencing these hot flushes, which because of which there is sleep disturbances in these patients. Next slide. So hot flushes can trigger awakenings in the first half of the night, but REM sleep in the second half suppresses this thermoregulation. Thus, hot flushes can decrease in the second half of the sleep. So, decisions on whether and how to treat with behavioral or drug therapy both depend on severity of the sleep disturbances, context, like because whether the sleep disturbances are because of hot flushes or any other stressful factors, we have to take into consideration all those things, and then we can treat all these sleep disturbances. And because of the sleep disturbances, they may have an impact on the next day, daytime consequences may be there. So if the severity of the daytime consequences because of the sleep disturbances are there, we have to treat the sleep problems as well. So all this because of this mood disorders, cognitive inability, dementia, these are all because of the stress factors and the menopausal age groups, because there is a gradual transition from everything. So all these are combined symptoms, and because of this, quality of life may decrease and sexual dysfunction may be there, and they may have like depression. So all together will contribute to this mood disorders as well because of the menopause. Next slide. Next slide. So for mood disorders, what we can do is lifestyle management is very important to treat in these patients. First thing is lifestyle management is relaxation and stress reduction techniques we have to offer them. Exercise is one thing which promotes the mood. So exercise in the form of either aerobic exercises or yoga can be offered to them. That there are some studies showing that aerobic exercises have an impact on the stress reduction, and counseling and caffeine intake can be cut down, and alcohol also can suggest them alcohol also to be stopped. So all this will help to improve the mood disorders in these patients. So urinary symptoms. Urinary complaints are more common in these people, but no link to menopause related in the midlife, but no link to menopause related estrogen loss has been identified. So over 50% of women of greater than age 50 with urinary incontinence also can have symptoms of overactive bladder. And mild incontinence, early perimenopause tends to decline in the first 5 years after menopause. What we have to suggest them is usually weight loss and Kegels exercises can be suggested for them. And Kegel exercises can cure more than 50% of cases of stress incontinence when performed regularly. So osteoporosis. The other long-term consequence of menopause is osteoporosis. Osteoporosis, like the severity of the osteoporosis, can be graded based on the T-score. The T-score and Z-score are taken into consideration when we are speaking about osteoporosis. Like what is the actual reason for osteoporosis is this is a lower estrogen levels, which account for about 2/3 of the bone loss during the 5 to 7 years around menopause. What does this estrogen levels do? What is when there is a hormonal imbalance or estrogen levels are lesser, there will be bone resorption from the bone. So and the osteoclastic activity also increases, which and also there is an increase in the free radicals also when our estrogen levels decreases. These all contribute to the osteoporosis. And 13 to 18% of white American women of greater than or equal to age 50 have osteoporosis of the hip. So that's why we see that fracture of the neck or the femur and all are very common in menopausal age group because the bone density decreases in all of them. So how are you going to categorize this osteoporosis? It depends on the T-score. T-score is they compare the bone in index bone density with an younger age group. One thing is T-score, and the other one is Z-score. T-score is with the younger person they compare, and Z-score is with the same age group they compare. So definitely T-score is taken into consideration. When the T-score is greater than or equal to -1 is normal, and the score less than or equal to -2.5 is osteoporosis, and in between -1 and 2.5 is low bone mass. That is how we categorize this osteoporosis. Next slide. So when you're speaking about osteoporosis, you have to also consider all the background risk factors are also we have to consider that. What are the risk factors for osteoporotic fracture? This is a fracture in 10 years they have kept in a calculator, and according to that we can calculate what is our risk of osteoporosis. Like what you take into consideration is advanced age is between 50 to 90, parental history of fragile bones, fragility fractures, and female sex, and tobacco smoking, weight, long-term use of glucocorticoids, height, rheumatoid arthritis, low femoral neck BMD, and prior fragility fracture, alcohol intake greater than or equal to 3 units daily, and other causes of secondary osteoporosis. So when you are calculating our risk factors, depending on this, we can calculate our osteoporosis risk factors or our osteoporotic fractures we can take into consideration. Next slide. Osteoarthritis, and studies of potential role for estrogen in osteoarthritis showed two very different findings. First, estrogen deprivation at the menopause seems to be associated with increase in the frequency of knee, hip, and finger osteoarthritis and severity of hip osteoarthritis. Second thing is menopausal hormone therapy for the menopause may decrease the incidence and progression of hip and knee osteoarthritis. Next slide. So cardiovascular disease. The long-term consequences of this menopause is cardiovascular disease, and particularly this level of this is in rise. The cardiovascular morbidity is increasing because much attention regarding the menopause or its consequences is not being paid for all the patients, and usually they're not aware of this menopausal symptoms and the long-term consequences. But the most common reason of death in women in our country is mainly because of the cardiovascular disease. Because of the age group, a lesser age group is also prone to this disease because of earlier menopause in our country. So it is the second leading cause of death among US women ages between 45 to 64. In our country as well, this is becoming the leading cause. And this increasing for the first time in 4 decades, secondary to obesity, diabetes, and hypertension. So when we are treating a patient with menopause, we have to take into consideration their background as well, like whether they're having any risk factors, any family history, any history of obesity, any history of hypertension, any history of diabetes. We all to take into consideration because in these patients, much attention regarding their health was not being paid. So we have to consider that and we have to educate them and we have to offer them protective measures from the earlier self, from early itself. Basically, cancer menopause is not associated with any increased cancer risk, but because cancer rates increasing with age and cancer, we have to offer them some follow up. Like if for every patient are we offering, or how are we offering them the changes? So, uh, it is a breast cancer. Breast cancer screening program. Actually, there is not a particular screening program in our country, but what NHS and others suggest is mammogram must be offered between every 3 years, not 2 years. It is 3 years between the ages of 50 to 71. And later, it is depending on the patient's condition. They will be offering this NHS mammogram will be offered. And colorectal cancer, everything, all this breast cancer, colorectal cancer, endometrial cancer, ovarian cancer, it's not mandatory that we screen all the patients, but depends on the background risk and depends on the symptoms they're presenting with. It's like colorectal cancer, if there is any fecal occult blood loss or any other symptoms that they're complaining of, then we have to say, go for the colorectal cancer screening. And breast cancer screening is mandatory that we offer them after every 3 years from ages 50 to 74. And endometrial cancer, depending again on the risk factors, like if they're obese or hypertension or diabetic or any particular background risk of endometrial cancer, we have to offer them. And any evaluation of postmenopausal bleeding, or if they're on HRT and the bleeding is not regressing, and if they're having constantly about this bleeding, still they're having, then we have to offer them this endometrial cancer screening, like endometrial biopsy, you can offer them. And ovarian cancer, there is no particular screening test for that, but we have to offer them follow up, regular follow up, and we have to ask them to come back if they're having any symptoms like weight loss or constipation or bloating sensation or urgency. If they're reporting all these symptoms and they're noting any changes in their abdomen, we have to offer them, though there was no satisfactory screening test for them because it cannot be detected at an earlier stage. But still, educating them is very important. Next slide. So cervical cancer. Cervical cancer screening is not again a part of menopausal screening. It's usually offered every 3 years. Like we don't have a particular screening program in our country. We don't offer, or we don't, most of them neglect this. Usually from the age of 25 to 50, it is offered every 3 years. So every 3 years they will be invited. They will be taken for a pap smear or cervical smear test. Latest is only the HPV testing they're offering. And after 50 years, it is every 5 years they offer this pap smear or a pap test. And once they're 65 years, if the previous three smears are normal and there are no abnormal cells, they can be just discontinued from this screening routine for this cervical cancer. But this is also not a part of the menopause. It's in general done for all the patients. So cervical screening cancer is offered much before menopause rather than the menopausal age. But we're remaining cancers because they are having but increasing incidence with increasing age groups. We have to educate them and we have to offer them proper screening depending on the symptoms and the background. Next one. So treatment, coming to the treatment of this menopausal age group. So we have basically two treatments, either the hormonal treatment or non-hormonal treatment. So hormone replacement therapy is a much have a better relief of symptoms when compared to the non-hormone replacement therapy. But again, here we have to take into consideration the patient options because there were so many studies and so many taboos in patients saying that hormone replacement therapy can have particular effects on their endometrium and breast also. So some people opt for breast non-hormonal therapy and some people opt for hormonal replacement therapy. So what are the forms of hormonal replacement therapy and who are the people that require this HRT? So hormonal therapy is used to replace the estrogen that ovaries no longer make during and after menopause. So it contains either the hormone estrogen or progesterone. So progesterone must definitely be added if the patient is having uterus to prevent the endometrial hyperplasia that is going to be happen when we are offering long-term estrogen therapy. So it is usually used for shorter periods, and it depends on the symptoms. We have to withdraw this hormonal replacement therapy, and also we have to give them, like we have to suggest them that if they observe any new changes of bleeding, or if they're having any other problems, they have to report immediately. That caution you have to give, and then you have to prescribe this hormonal replacement therapy. And hormone replacement therapy can be in the form of tablets, patches, or creams. And estrogen can be given in the form of a ring, and progesterone in the form of tablets, or you can also place a intrauterine contraceptive device also, like Mirena also can be placed when you wanted to give a progesterone supplement. And next slide, please. So, indications of HRT, like if patients are presenting with severe vasomotor symptoms, or any osteoporosis and a background risk factor is there, and to maintain the quality of life, because some people are they have this urinary problems, and they will be presenting with vasomotor symptoms, severe mood disorders, and all these things. To improve the quality of life, we can give this HRT. And people who definitely require HRT is because premature ovarian failure. Premature ovarian failure is the loss is a menopause before 40 years of age. So because they have long-term consequences in these patients, we can offer them HRT. And gonadal dysgenesis and surgical or radiation menopause, but an younger age group also, we can have a, offer them HRT, you can be giving them. So how are you giving them? Either in the form of cyclical or sequential or continuous we are giving. Cyclical or sequential or continuous. So who are the persons which we give sequential therapy, and who are the people who we give continuous therapies? Already who are menopausal, we give them continuous therapy. And who are perimenopausal and still having the periods but still having this symptoms of menopause, we can give them a sequential therapy. So depends on the patients, we can give them either sequential or continuous therapy. So whenever you're giving HRT, be mindful that you tell them that they notice any bleeding changes, because sometimes they can have this bleeding or spotting, which generally regresses after 2 to 3 months. That is a deadline. If still they're having bleeding in between, or excessive bleeding, anything, we have to ask them to come back immediately and report. And we have to rule out if any other problems are there in this patient, particularly endometrial hyperplasia also must be ruled out. Next slide, please. And what are the risks of hormone therapy? So whenever we are prescribing them, you have to be mindful to evaluate the patient and rule out if there are any contraindications for HRT, and then only we have to start the patient on HRT. Like if they're having an history of endometrial cancer and any clots in the family, like venous thromboembolic disease, or any breast cancers, ovarian cancers, and increased because of the lipid metabolism. What happens is when you're giving here, increased instance of gallbladder disease have also been observed after ERT. So that thing, and lipid metabolism, LDL cholesterol, when they're having high triglycerides, or when they're prone to further cerebrovascular risk accidents, we have to take into consideration, and then only we have to start HRT. And in cases of breast cancer, if progesterone is usually you have to rule out like what type of cancer, and then you have to be mindful when you're giving a breast cancer patients with a HRT. If they're having severe symptoms, what to do? Severe symptoms without, if they're not having uterus, you can at least give estrogen only HRT also in these patients. But be mindful again to rule out everything, take into consideration the risk factors, and then only we can start them on hormone replacement therapy in such patients. Next slide, please. So the same thing, because hormone replacement therapy and risk of breast cancer, because the background risk can increase when you're taking hormone replacement therapy with breast cancer. But when you stop this HRT, the risk of breast cancer in these patients is almost similar to the normal background patients. So there is no increased risk. Only that risk will be when you're taking, and once you stop, there will not be any risk in these patients. So you can give them, but you have to be keeping them under, you have to keep them under monitoring. Next slide, please. Next slide. And progesterone therapy, you can, with history of breast cancer or endometrial cancer, progesterone may be used if it may be effective in suppressing hot flushes and prevent osteoporosis. Medroxyprogesterone acetate 2.5 to 5 milligrams day can be used. Apart from this, you can either give an intrauterine device also for the progesterones. Next slide, please. And tibolone. Tibolone is another is a steroid having estrogenic, progesterone, and androgenic properties as well. And but it prevents osteoporosis, atrophic changes of the vagina, and hot flushes, and it increases libido. A dose of 2.5 milligrams per day is given. In these patients also, the background risk for breast cancer can increase with tibolone. So you have to be again telling the patient about all this. If they identify any changes, they have to report back immediately. And next, coming to the black cohosh, and we have spoken about the hormonal replacement therapy in the form of hormones now. Non-hormonal complementary therapies is black cohosh is one of the herbal medicine which is being prescribed for the non-hormonal therapy as a complementary part. But what happened is we in this herbal preparations, what happens is we really don't know what is the amount of drug being delivered or what are the interactions with other drugs. So definitely we have to take this on table medicine because so many people will be taking this without any prescription. So we have to be mindful when we are prescribing these patients. And we're taking into consideration the black cohosh. It has been reported that a lot of liver toxicity and interactions with other drugs has been identified with black cohosh. So the committee reviewed case reports suggesting a potential link between ingestion of the extracts and liver damage. So we have to be mindful when we're prescribing these drugs because we really don't know what is the dosage, and there are not many studies showing the effects of these drugs. So that we have to take into consideration when we're giving this one. And liver toxicity, definitely the risk of liver toxicity is much higher with black cohosh. Next slide. So the same thing again, involve liver problem, and when you're taking the herbal supplements, we have to seriously read all the warnings about the drug, and then we have to take. Next slide, please. And then other complementary drugs which we can offer in these patients is isoflavones. Isoflavones are of two types. They are either in the phytoestrogens, phytoestrogens. Phytoestrogens are two types. One thing is isoflavone and the other one is lignans. So isoflavones again of the two types like genistein and the other name is genistein is one thing. Then exposure to this cause mammary gland and pituitary gland edema in the female rats. And exposure for shorter duration following birth was also possibly associated with increased rates of pituitary gland and mammary gland tumors. So isoflavones also have this slightly estrogenic actions. So isoflavones could be toxic because it's a high level of hormone-like action, and it could be hormone dependent cancer causing material also it can cause. So we have to be very mindful when you're giving this isoflavones also. Isoflavones are rich in like soya, all the soya derivatives and all are rich in isoflavones. So when we are giving them, we have to be taking again into consideration if the patient is having any endometrial cancers or history or background risk is there, or also we have to, and continuous supplements with these isoflavones must also be avoided in these patients because they can have this estrogenic activity, which can be again causing this proliferation in this endometrium. Next slide. So when we have seen this studies showing that because of this, they don't have much effect. Soya isoflavones in the prevention of menopausal bone loss and menopausal symptoms when RCT was done, it concluded that in this population, tablets containing 200 milligrams of soya isoflavones did not prevent any bone loss. So they don't have much particular effect on the bones when isoflavones when compared to other symptoms. Next slide, please. So there are various therapies which we usually offer in this menopausal symptoms, which are like SSRIs, serotonin reuptake inhibitors, SNRIs, and clonidine, all these things. So when we consider each of them, coming to clonidine is in what happens is there are studies showing that hot flushes are relieved in this, but not all the studies didn't have much effective studies are not there. And also they have serious side effects like dry mouth, drowsiness, fatigue, and constipation. So this is what clonidine about. And gabapentin has definitely a more role because it improves the sleep quality of the patient as well, and also tends to be more effective in these patients, like with sleep disturbances. And when we come about all the SSRIs, SNRIs also have a role in treating the vasomotor symptoms like hot flushes. But we have to tell them that they have severe nausea and loss of libido with all these drugs. So you have to be telling that patient, and compliance is also very less with these drugs because of this nausea, whatever changes in the bowel habits and nausea, because the compliance with these drugs is also much lesser compared to other drugs. So you have to tell the patient first initially itself, like these are the side effects, and this is how we can slowly increase the drug dosage instead of starting at a higher dose. And the interactions with other drugs also we have to mention. Loss of libido is also a very common side effect of all the SSRIs. Next slide. So now we have a new herbal ingredient. We have seen the hormonal replacement therapy, and we have seen the other herbal supplements we have seen, and we have also seen like what are other drugs which can be given for the vasomotor symptoms like clonidine, SSRIs, SNRIs, and all. So now we have a new herbal ingredient like estrogen, which is again a herbal extract containing three herbal extract was chosen. And when the safety was also proven when compared to other herbal supplements, here the safety is well proven. About 400 years of documented use in Korea as a folk medicine, and registered as safe food ingredient in Korea food code. And also they have a liver protective effect instead of liver toxicity. They don't have any liver toxicity, and instead of that they have a liver protective effect according to the WHO. And they can also, when the studies were done in rats, there is no increase of uterus weight, and also inhibition of proliferation of human breast cancer cells, and no binding affinity to both estrogen receptors alpha and beta as well. So they're not acting on the estrogen receptors, so that don't have any estrogen toxicity as well, and also they're liver protective when compared to the other herbal supplements. So it is a proven efficacy in vitro, in vivo, and three human groups clinical studies. This efficacy of this drug was much higher and better when compared to the other herbal supplements. Next slide, please. And it also proven efficacy 62% improvement of the quality of life in most of the patients, and 10 out of the 12 climacteric symptoms significantly improved compared to placebo. So what are all the improvements symptoms is hot flushes and night sweats are improved, and insomnia, paresthesia, nervousness, and melancholia, vertigo, fatigue, rheumatic pain, formication, and vaginal dryness. So all the symptoms were improved after taking this estrogen, which is again a herbal supplement. Next slide, please. So again, a Cooperman index for moderate to or severe menopausal symptoms improved. So what is Cooperman index? Is like when you see this, they take into 11 questionnaires. It is a questionnaire based on the improvement of the symptoms. There are 11 questionnaires like what are all the symptoms that improved when you give this particular drug and the placebo. So when estrogen was given, there are much better improvement of all the symptoms in according to the Cooperman index or the questionnaires which we asked in. So definitely it plays a role in treating menopausal symptoms when compared to the other herbal supplements. Next slide, please. Vaginal dryness also improved, unlike plaque cohesion isoflavones. After taking this herbal supplement, estrogen, we can see in this graph that the changes of vaginal dryness and reduced libido during 12 weeks of administration of each estrogen and placebo. So we can see that there is much better improvement in all the studies which were done on this. Next slide. So what is the other option? We have spoken about the medical treatment, herbal treatment, non-hormonal treatment, and other medicines. So first thing, apart from all these things, what we have to suggest a patient is definitely lifestyle management. So three-step management of eat right, good physical exercise, and medications. These are all very important for these patients with menopause. So what is next slide, please? So what is this therapeutic lifestyle management is physical activity like aerobic exercises and yoga and targeted exercise, nutrition, avoid alcohol, tobacco, stress reducing strategies, meditation, paced respiration, massage, emotion stability, positive attitude, and family involvement, spiritual attitude, sleep. Along with this, all these are the suggestions which we can give the patient to treat this menopausal symptoms. And definitely it is important, like emotional instability can be will be much higher in this patient. So family involvement and support is the one thing which we have to offer them. And apart from this, the clothing also is very important in these patients. We can suggest them to take light weighted and light colored dresses, and also which facial coolers will be there, that we can suggest them when they have this hot flushes. So clothing is also very important for these patients when we suggest the lifestyle management. Next slide. So living, we have to take a balance in nutritional food, which includes all the carbohydrates, which are important, and pulses, fruits and vegetables. Everything must be given to them in a balanced way, so that the balance in nutritional diet, along with calcium supplements and calcium-rich foods, must be given for them, along with vitamin D also. Next slide. So what are the recommendations given by the Indian Menopausal Society is sugar tea 6 teaspoons per day, salt is 1.5 tablespoons or 3 to 5 grams per day, and oil is 2 tablespoons per day, and fruits are definitely 100 grams per day, and vegetables 300 grams per day, and drink 8 glasses of water every day. Add powdered flaxseed, cinnamon, fenugreek, and soap in salads and curds. These are by the Indian Menopausal Society recommendations. And avoid more than 200 milligrams per day of caffeine. Limit intake of tea and coffee to 3 cups a day, and 1 cup of brewed coffee is equal to 120 milligrams of caffeine, and 655 milligrams for 1 cup of instant coffee and tea. Consume a minimum of 500 to 600 ml of milk or curd, low fat weight on calcium bank in bones. Support it with lots of vitamin C rich fruits or vegetables to favor calcium absorption. Living with sleep hygiene is also very important. Go to bed and get up at the early in the day, and sleep in a dark, quiet room and comfortable temperature. Avoid large meals, exercise, stop nicotine, and definitely maintain dim light bedroom environment with no gadgets around. And required RDA for calcium and vitamin D for adult Indian. This calcium is greater than 800 milligrams per day to 1200 milligrams per day, and upper limit of normal is 2,500 milligrams per day. Vitamin D 1500 to 2000 international units, and upper limit of normal is 10,000 international units. Calcium supplements, you have to thyroid medications, corticosteroids, tetracyclines, anticonvulsants, and calcium should be taken separately because they may have drug interactions, and contraindicated in patients with hypercalcemia, renal insufficiency, and patients with nephrolithiasis. Excess amounts more than 2,500 milligrams a day affects kidneys and reduce the absorption of other minerals like iron, zinc, and magnesium. So you have to be mindful when you're prescribing that. And cholecalciferol vitamin D3 tablet or powder, 60,000 international units once for 8 weeks, preferably with milk, or one iron injection of 6 lakhs international units is given to correct the deficiency, to be repeated before 3 months, and may be given confirmation of persisting low levels of vitamin D. Maintenance therapy from natural sources or supplements is advised after correction of the deficiency. So conclusion is, women live 1/3 of their lives in postmenopausal period. So educating them about all these effects is very important. And apart from, we have a lot of programs like in RCH, like rural child health and all pregnant patients and menstrual problems we have. But this also must be included, that in the menopausal period also must be included in the special category forms, to offer appropriate education and nutrition to these patients. And Perimenopausal and postmenopausal women may be affected by symptoms with hypoestrogenism like vasomotor symptoms, vaginal dryness, and osteoporosis. So always prevention is better than cure. So you have to educate them. We have to give them good supplements and start them on calcium-rich diet, and we can offer them lubricants, and we can also educate them regarding how to manage with these vasomotor symptoms. And in most women, hot flushes usually resolves without treatment. As a HRT has its severe drawbacks, non-hormonal management is the best choice of menopausal issues. Complementary and alternative medicines is an important treatment strategy. Eating the right diet along with the supplements, having adequate sleep, and exercising regularly will give you a blissful postmenopausal life. Thank you.
Thank you, ma'am. Thank you very much for that wonderful presentation, ma'am. It is always an honor to hear to you, ma'am. Ma'am, let me wait for 1 or 2 minutes for the participants to post their queries, ma'am. If there is any queries, I will read for you, ma'am.
Okay.
And ma'am, like I have few queries, like ma'am, what is the what will be the difference between this operative, that is hysterectomy, ma'am, people undergoing hysterectomy, and this natural
Yeah.
medicine? Is there any major difference in the symptoms wise or any other physiology?
Yeah, because in natural menopause, the symptoms are they will be only slowly they will be emerging. Whereas in surgical menopause, abruptly, because of the loss of the ovarian function, they have abrupt symptoms. Because in natural menopause, body will be slowly acclimatizing to all the changes in the body. But whereas in this surgical menopause, because suddenly you are withdrawing all the hormones, there will abrupt changes. So they will take longer time to acclimatize to all these changes, and they may be having experiencing more symptoms because in this it is a progressive thing, and that is in a sudden change.
So, ma'am, is that advisable to take this non-hormonal treatment for this type of patients, ma'am? Whether if they're going to take for long term, like
Yeah, long term as definitely non-hormonal therapy they can be suggested, because hormonal therapy they can have each one have their particular risks, and we have to consider the patient's risk factors and background. We have to check and what are the what are the symptoms they're facing. We have to take into consideration all these things, and then we can treat the patient.
yeah, ma'am. Ma'am, and we have also had one more case, ma'am, like the woman attained her menopause at 50, but up to 70 there was no symptoms, ma'am. But after 70, the symptoms gradually increased and it went even severe, ma'am. So, what could be the reason for that type of patients, ma'am, after 70? Is there any specific reason?
Maybe because usually the menopausal symptoms will be after menopause, it will be only 2 to 3 years they will be having, and
Yeah,
perimenopause
ma'am.
people 5 to 7.
Yeah, ma'am.
Probably sometimes what happens is there was a slow decline in estrogen levels because of the other stimulation like peripheral conversion of estrogen will be having,
Mm.
and because that amount maybe she's sustained in her body or something, and after that after complete regression of all these hormones she may be experiencing that symptoms, but that happens very rarely.
Okay, okay.
Mm.
Participants, if you have any queries, please post to the chat box so that we can raise to the speaker today. Is there any vaginal estrogens applicable? So that is applicable estrogens available, ma'am?
Yeah, Long cream, that is a
Okay.
local vaginal cream, estrogen cream, you can give that.
How long they can take, ma'am? This when it comes to this.
It depends on
Uh,
their severity. Like lubrication is very difficult, or they
mm,
have difficult, very severe dyspareunia, vaginal dryness. They can be offered because the local absorption of this vaginal gel is very less. So they can be taken. They can be taken safely, unless until they're having any severe contraindications.
okay. Ma'am, how to manage postmenopausal symptoms in cancer patients? They have not mentioned the exact cancer, but they are asking like how to manage postmenopausal symptoms in cancer patients.
Depends on what type of cancer they're having. If it is breast cancer, because definitely progesterone component is not advisable in them. And if it is estrogen based tumors, instead of giving them tablets, we can give them patches or gels that can be because they don't have systemic absorption much. So it depends on the type of cancer they're having. So if they're having severe menopausal symptoms, which definitely needs this estrogen therapy, the way of the mode of transfer, drug delivery can be different. Like it can be in the form of a ring or patch or gel or something like that we can give.
Now, I have this question, ma'am. Is there any particular indication that this type of patient should use only this type of estrogen, or whether it is contraindicated in any patients from this types of estrogens, ma'am?
Yeah, oral estrogens because if they're having any risk factors if they're having any previous history of clots or like in the family history of clots where estrogen is definitely not recommended in those patients, but still patient is having severe vasomotor symptoms or severe hormonal problems like menopausal symptoms, we can give them in the form of a gel or a patch, we can give them instead
Okay,
of giving the orally.
okay, ma'am. Ma'am, we don't have any questions in the chat box, ma'am. So if
Okay.
there is any queries, then we will be forwarding to your email ID so that we can address all those queries, ma'am. So if
Okay.
you allow us, then we can end the webinar for today.
Okay.
Yeah, ma'am. Thank you, ma'am, once again for being with us today, ma'am. It's wonderful hearing you, ma'am. And ma'am, we are looking for many more webinars from you in various different topics related to women's health, ma'am. Please do support us in your webinars, ma'am.
Definitely.
Thank you, ma'am. Thank you very much, ma'am.
Thank you.
I would
Thank you.
like to thank my team for organizing this webinar also. Thank you, ma'am. Thank you.